Hello, I'm David Cohen, Director of Cardiovascular Research at St. Luke's Mid-America Heart Institute in Kansas City, and welcome to TCT Asia Pacific 2014. We're here in Seoul on the second day of the meeting with several colleagues and old friends and new friends. So we're going to be talking today about issues with anti-platelet and antithrombotic therapy in PCI. And so we have a number of studies that we want to talk about. Some of them are summarized on these slides that I'll run through fairly quickly. And then I'd just like to really have a bit of a free-flowing discussion about issues that come up in conjunction with these slides. So we will be talking about dual antiplatelet therapy after drug-eluting stents, both in terms of what the guidelines recommend and some of the recent clinical studies that have come out in the last year. And then in the second portion, we'll switch over and talk about anticoagulants, antithrombotic therapies, again, starting with the guidelines and then going to a number of clinical studies, the TAO study and the EUROMAX study, and then hopefully actually transitioning over to talk about the HEAT PPCI study that generated so much attention at the ACC. So in terms of dual antiplatelet therapy, we all know that dual antiplatelet therapy is critical after PCI and an ACS. This is our current guidelines. The ACC-AHA guidelines recommend at least 12 months of dual antiplatelet therapy after drug-eluting stents if patients are at not high risk of bleeding. And the ESC guidelines recommend 6 to 12 months, so a little bit more leeway there after drug-eluting stents in all patients, and 12 months in all patients after an acute coronary syndrome. In the last couple of years, there have been a number of studies that have started to challenge some of this dogma in a variety of different directions. This is a study that was led by our Korean colleagues, by Dr. Park, and many of his colleagues here in Korea, called the DES Late Trial, where they took almost 5,000 patients after drug-eluting stents who were free of major adverse events at a year, and randomized them to continuing on dual antiplatelet therapy versus discontinuing it, and again, treating for at least 2 years with dual antiplatelet therapy. And what they saw in terms of ischemic events was very low event rates in both groups, with no significant difference whether the patient was on extended dual antiplatelet therapy or shorter dual antiplatelet therapy, and a somewhat higher risk of bleeding in the patients who are on extended dual antiplatelet therapy. But again, the event rates here are quite remarkably low. Major adverse cardiac events, cardiac death, MI, and stroke of about 2.5% at a year. You can see the confidence intervals there are moderately wide in terms of the relative risk. Another trial that just came out during the past year, I think was presented at the ACC and published last fall in JAMA, was the Optimized trial. This was led by a Brazilian group. It studied a specific stent, in this case the Endeavor drug-eluting stent, the rapid-releasing zoldarolimus-eluting stent, and these patients were then who were a relatively low thrombotic risk group, were randomized to 3 months versus 12 months of dual antiplatelet therapy, and again, with a very short duration of dual antiplatelet therapy, absolutely no difference in major adverse cardiac events, and again, a reduction in bleeding seen with the shorter duration of dual antiplatelet therapy. And then we had this study that I was involved in. Roxana Meron led this registry-based study looking at patterns of discontinuation in the real world. So this was 15 sites in the United States and Europe, patients who received drug-eluting stents, and then she characterized each patient who came off off dual antiplatelet therapy in terms of whether it was discontinued, meaning that the physician directed that this was okay to stop the dual antiplatelet therapy. It was interrupted, meaning the physician said it was okay to stop it, but you need to go back on it. And then disruption, which was something unintentional, either a medical event occurred or the patient discontinued themselves. And what she found was actually if it was discontinued in the first year, or if it was interrupted in the first year, there did not seem to be an excess of major adverse cardiac events. But if it was disrupted, if something medical occurred that led to it being discontinued, you can see there was a substantial increased risk of MACE, particularly if this happened in the first 7 days, a very high-risk period, with a declining trend over time. So I think a provocative study just in terms of the discontinuation patterns, although it's a little hard to figure out exactly what to do operationally with this. Can we tell a patient we're discontinuing it when they're really interrupting it, and will that change how it works? I'm not quite so sure. And then this is the study that many of us have been waiting for, which is not yet presented or released. This is the DAPT study that Laura Maury from Harvard has been running for the last 4 or 5 years now. Multiple different drug-eluting stents, both first and second generation, as well as bare metal stents. And this was really designed to, with relatively definitively, answer the question of is there any benefit in extending the dual antiplatelet therapy? It's not looking at the shortening of dual antiplatelet therapy, but extending it from 12 months to 30 months in a population of more than 20,000 patients. We anticipate the results of this trial coming out sometime in the fall. So, a couple of just points of discussion. These are the background, the foundation of what we want to talk about. But let's just talk clinically. And talk about, we have 2 different U.S. centers here and a center from Paris. What do you do right now with your elective PCI patients? What is the pattern at your institution? What do you recommend to them? Do you have a standard? So we'll start down the end here with Manesh.
Thanks, David. A great overview. And I guess I'll say that in the elective setting, not the acute coronary syndrome where there's an indication for 1 year, if a drug-eluting stent is placed, we're still recommending, without contraindications, 1 year of therapy. Of course, we recognize for a lot of patients there's a lot of reasons they can't do it. But I have to say with clopidogrel coming off patent and being generically available, it's certainly an opportunity for our patients to get at least more therapy. So routinely right now, drug-eluting stent implantation, unless there's a contraindication, an upcoming procedure, we're saying at least 1 year.
Okay.
I will tell you that certainly the number of patients where we push very hard at the end of 6 months to say, oh, you have to stay on it, all the procedural lists, the colonoscopies, the things you hear about, I think we all feel a little bit more comfortable at that point having a window come in and do those procedures.
So a little more comfortable,
a little
with
bit
shorter,
more lenient,
but still recommending 12.
Still recommending 12. Again, not based on a tremendous amount of evidence. Recognize the treatment realities there with the lack of evidence there for that.
Jean-Philippe, what about in Paris?
So in our institution now it's 6 months, at least 6 months.
At least?
Yeah, at least.
Just like the guidelines say, I think.
Yeah, just as the European guidelines say. And then we have added some important points is that it can be discontinued after 6 weeks for planned surgery.
6 weeks?
Yeah.
Okay.
If needed.
Mm-hmm.
But the recommendation is at least 6 months. And most of people now are sticking to 6 months for elective PCI.
Okay. And Neal?
We're still a minimum of 12.
Minimum of 12.
And that's stated if tolerated and knowing that we may get a very different answer at the end of this year.
And what do you do at the end of 12 months? So, 6 in Paris. So I know, because I was on the steering committee for the DAPT trial, one of the real challenges we had in that trial, at least at the time, was many patients who were tolerating their dual antiplatelet therapy well at 12 months. Physicians were reluctant to discontinue the clopidogrel. They said they're doing fine. Why stop? So what do you do with that, Jean-Philippe? At 6 months, if they're okay, do you stop? Or at 12 months?
Well, personally, this is what I'm doing. But we have the experience of with the Arctic trial, which was first designed for looking at measuring the effect of antiplatelet agents and adjusting therapy. And at the end of the first year, people were re-randomized to stop or to continue on clopidogrel. And they were mainly DS, 100% DS, and about 1/3 were having ACS,
okay,
non-STEMI patients. And what is interesting is that we have all the biases that are, usually seen in interruption studies. So we had about only 40% of the patients that could not be re-randomized after 1 year. And this is mainly because they have an event, or also because the doctor were reluctant to stop therapy.
Mm-hmm.
And those patients who were not re-randomized were at much higher risk than those who were eligible for re-randomization and then stop and continue.
Right.
So this is just to highlight the fact that the picture that we have from the interruptions trials are, not the real picture of the real patients.
Right. And the patients who get to 12 months and then you can re-randomize are a special group. I think that's
right. They are usually at lower risk. Mm-hmm. And you do not really ask yourself the question whether we should stop or continue, because there is no great risk in terms of ischemic events.
So do we know the results of the Arctic continuation phase?
It was presented at the TCT meeting.
Right.
And it's going to be released in the Lancet. And we did a meta-analysis, all the data we have, and there is no hint of benefit in terms of ischemic and more bleeding events.
And this is for extension beyond 12 months?
Yeah, it was 2 years versus 1 year.
Great.
Yeah.
And Manesh, so what, your patient gets to 12 months, they're doing fine. What do you do now?
I think you've highlighted, and I think we've highlighted now that there's several lines of evidence that there isn't clearly a benefit beyond 12 months. And let's remember how we got here. I think in 2006, with the concerns of stent thrombosis, many interventionalists and much of the community said we really have to extend dual antiplatelet therapy. And we've learned now over time that maybe those observations clearly were real, but we're probably in the face of 85, 90% DES penetration into our clinical practice, all the types of patients we could put stents in. And now maybe we're at 70 or 60, and certainly the pendulum has swung. So I would say this is like a lot of things we're going to talk about is our learning over time with how to use the drugs. For the specific patient in front of me, I speak to him clearly saying, you know, I recognize there's always worry and fear about stopping a medication when everything's going so well. But there's sometimes risks with medications that you can't always see, and one of those is bleeding, and certainly the ability to take two therapies, and then, of course, adherence to other medicines you need to be on. So after that conversation, which actually takes longer, and it's harder work than just saying keep going on the clopidogrel, we may make the decision to stop at the end of 12 months.
There's one thing that gets overlooked in this discussion. There are two things. First of all, the points that Jean-Philippe brought up. Identifying patients at the time of implant with planned discontinuation is very different than looking at patients who've been event-free for a period of time and have shown you that they're lower risk. The other thing that never gets talked about is there are a lot of patients we take care of who still have first-generation stents.
Sure.
And to say, well, it's no longer a problem with new stents really obscures half the picture, because we still have a responsibility of making those decisions in people running around with Cypher and Texas stents.
Well, I don't disagree. I just think that by now those patients are now 4 or 5 years out, let's say, on average, maybe not quite. And so the conversation's even more pronounced. You know, they've either shown themselves to be responders of the dual and not had an event, or those that have had to
but we
stop
still
it.
see. I mean, you know, I
I
got an email last night
clinic,
from patients. Patient came in just to our hospital overnight with a late DES thrombosis. You know, very late thrombosis, 5 years after a Cypher. You know, I mean, that's
no
still happening.
question.
Right?
And I think we'll continue to see it even with the new ones. The real question is prolonged DAP going to change?
Is it going to help?
Has anything to do with
but
that?
I agree with the point that was raised by Neal. That and in the Arctic trial, we found a real interaction, between the risk of events and the type of DS. It was 100% DS, and there was a huge difference between the first generation DS and the second generation DS. And there's another point that I would like to make and to outline is the crossover. And usually in these interruption trials, there is no real mention about crossover, and it's very difficult to handle this issue and statistically. And I mean, it's another bias that we should look for.
No, it's impossible to adjust for that. Let me switch gears just a little bit and talk about a specific.
Bring up one last concern.
I hope it's the same one I'm going to talk about.
But the other concern I have is I don't know how long you have to follow someone or follow a group of patients off DAPT before you can declare that they're successfully withdrawn. It may take only a single brief prothrombotic tweak to take someone who's been stable for several years and cause them to have a late thrombosis.
Well, that certainly is possible as well, surgery or cancer or any kind of other sort of thing. Let me just switch gears for a quick second and talk about, I know what is one of your pet interests, Neal, which is atrial fibrillation in these patients, which is a real challenge for us with patients with, who receive stents and have atrial fibrillation. And let me just ask a provocative question. If you have a patient who has atrial fibrillation and is taking an oral anticoagulant, say warfarin right now, do you use a drug-eluting or a bare metal stent for that patient, and why? And let's start down this end to give Neal the first word on that. And then what do you do with the anticoagulants?
Okay. Well, I try to use a bare metal stent, but not all lesions are favorable for bare metal stents. So we often do end up using drug-eluting stents. And I think some of the more recent data may suggest that we're being a little too conservative. What do I do with anticoagulants? I think the best data we have now are from the West trial.
Small study.
Small study, many flaws, but truthfully, it's pronounced worst, but it's the best we have. So I treat them with a single dose of aspirin, purely empirically, and then it's warfarin plus clopidogrel after that.
And then how long do you keep the clopidogrel going?
A year.
The same year. Jean-Philippe, what is the
This
standard
my
in Paris?
Personal view.
Okay.
So it's 100% DS.
Okay.
Because thrombotic profile of new DS is exactly the same as BMS, and then there is the issue of reintervention with the BMS, and with all these bridging issues, and then you get more bleeds and more accidents that are always unexpected. Triple therapy is only 6 weeks for myself, and then I switched to dual therapy, maintaining anticoagulation, usually with aspirin.
So aspirin, not clopidogrel.
Not clopidogrel.
Okay.
Yeah.
Any special reason why you've chosen aspirin?
Well, I think that we do not have data to favor clopidogrel or aspirin, and clopidogrel was mandated in the WORST trial because the investigators did not want to do the study if clopidogrel was not on board.
I see.
So,
Okay.
I mean,
So they were not as willing as you. So 6 weeks of triple therapy
right.
followed by dual therapy.
Right.
So you wish that there were a third limb in that study.
Yeah, perhaps and that's with 100% drug-eluting stents. Do you care which drug-eluting stent of the second generations?
Well, it's what I have on the shelves. That's
Okay.
it.
Manesh?
Well, let's say it highlights sort of the differences in practice and probably where we are with evidence. I guess I would say first, if there's not, again, this is an elective setting, not an ACS setting, so again, not an indication for a long term. In the elective setting, I think, as you were saying, there are three things. One is the first generation, second generation stent question, but the second is the patient profile. So there are AFib patients that are 50, and there are AFib patients that are 75 with lots of comorbidities. The latter group, the AFib patients that are 75 with a lot of comorbidities, we generally put bare metal stents in because of all the other things going on with the patient. The patient, again, that's younger, maybe not as many risk factors, a lower CHADS, FASC, somebody that you're going to even have those questions around, I think we would argue that that person might be a candidate for DES. In general, though, probably our practice in our cath lab is about 70 to 80% bare metal, again, because they're high comorbidity patients. And I'll argue on the other side that there's no way they're not going to get oral anticoagulant for their lifetime for stroke prevention. And so the only things you're now talking about are something around restenosis, which is fair,
Right.
or questions around the bleeding risk,
Bleeding
which
risk.
becomes exceedingly high in these patients.
Right, and associated with mortality and lots of bad things.
It doesn't mean that this regimen described isn't great. I think it is a great regimen. I think we're all going to have to study the regimen.
we've struggled in our own group. We like to have protocols for things, and we 11 of us all sat down together and said, "Can we come up with a protocol?" And we had 12 ideas. I think it defied logic at this point. But I do think the issue of drug-eluting versus bare metal stent is a fascinating one. There was a trial, which I didn't have the slides of, called the Zeus trial that was just presented at the most recent ACC that Marco Valgamigli did, where he compared Endeavor drug-eluting stents versus bare metal stents with varying anticoagulation regimens depending on the clinical scenario, not on the stent, and found that there was a substantial advantage to the Endeavor stent in that setting with lower target vessel revascularization, lower stent thrombosis, lower MI rates. It looked like a real winner. Now, can we still get the Endeavor stent in the United States? I actually don't.
The Endeavor Sprint.
Right, but it's it's not the Resolute. It was the original Endeavor.
Quickly eluding.
Yeah.
But it really shakes up our dogma. I find it a very pleasantly disruptive trial. I wish we had many more trials like that.
Yeah.
No, I think so as well. I think I want to just move on and talk a little bit about anticoagulants. In terms of anticoagulants in acute coronary syndromes, we have, again, the ACC and the ESC guidelines to look at. And so the ACC guidelines for non-STEMI recommend either unfractionated heparin, enoxaparin, or fondaparinux, which you can't even get in the United States for this indication. And for STEMI, we have recommendations to support unfractionated heparin or bivalirudin. The ESC guidelines are, as usual, a little more clear and dogmatic, and they say fondaparinux is better than enoxaparin, which is better than unfractionated heparin in non-STEMI. And for STEMI, they give you a choice between unfractionated heparin or bivalirudin. The data for fondaparinux comes from this very large-scale trial called OASIS 5, conducted a number of years ago in non-ST elevation ACS, comparing fondaparinux versus enox, which showed no difference in the composite ischemic endpoint, about a halving of the risk of bleeding, and very importantly, a reduction in mortality with fondaparinux compared to enoxaparin, but a trade-off with catheter thrombosis, which has made most of us as interventionalists pretty reluctant to use it because you have to give heparin in order to take them to the cath lab. A trial that came out just in the last year, the TAU trial, a European study looking at otomixaban as compared to unfractionated heparin and a 2B3A inhibitor, showed no benefit of this novel 10A inhibitor. with excess bleeding with otomixaban. So I think this one probably is not going to be a big high choice for any of us. No benefit and harm, and undoubtedly a more expensive drug than unfractionated heparin or enoxaparin. And then here's the French study. Just recently completed and presented at the TCT, the EUROMAX trial, which was a STEMI trial, which took advantage, I think, of the unique setup in France, where patients have physicians who are present in the ambulance. And so this was a randomized trial that started in the ambulance of bivalirudin versus heparin, with 2B3A allowed on at the operator's discretion. And in fact, most of the patients in the heparin arm, about 60%, received the 2B3 inhibitor in this trial. And so it was optional but fairly highly used in the heparin group. And you can see here there was a significant reduction in the primary composite of death or major bleeding at 30 days. But there was an important excess of stent thrombosis early on in the bivalirudin-treated patients, which echoed what had been seen in previous studies like the Horizons AMI trial. So again, no difference in mortality, really a very weak trend towards a mortality reduction at 30 days in this study. So, this is the landscape with respect to anticoagulants and ACS. So I want to ask what you're doing, and I want to focus actually right now on STEMI, just because because I want to transition and talk briefly at the end about the HEAT trial that was presented at the TCT. So let's roll back 6 weeks ago, before the ACC, and say what was your your practice? What were your recommendations in patients with STEMI? And Jean-Philippe, you get to go first this time.
Okay, so the first point I would like to make is that there is a huge gap between ESC recommendation and what is the real practice on the ground. And this is true for non-STEMI with fondaparinux. Only 5% of centers are using it. Mm-hmm. And it's the same for STEMI with bivalirudin, which is almost very infrequently used in the cath labs, probably because of the price and because people were not convinced about the Horizon trials results because of the asymmetrical design of the trial.
Right.
So in my institution, it's 100% enoxaparin IV for STEMI patients. We have been doing that since 10 years. We have registries, and we have the Atoll trial versus UFH using radial and GP2B3A. And so we are quite convinced that it's a cheap and good strategy, which is safe.
And just to finish up the picture, what antiplatelet strategy are you using predominantly in your STEMI patients?
We are using of course aspirin, and in STEMI we are mostly using Prasugal.
Prasugal for
loading dose. Yeah.
And 2B3A very little,
well,
or
2B3A it has the physician discretion, so it can be used as a bailout. Once the CAT has been done. And it can be also used upstream, and this is a decision of the MICU people. And if the patient has a low bleeding risk profile, and if it's an extended MI presenting very early and less than 75 years old, then they use IV GP2B3A, and it's about, I would say, 15% of these patients.
Okay, so modest percentage. And Manesh, what's the Duke practice as of 6 weeks ago?
Well, I'll tell you, I think this is interesting because, again, this highlights the differences in Europe and in North America, or at least the United States. If you looked in the United States right now, for all PCIs, bivalirudin is used 65 to 70% of the time across the country.
Incredible difference.
Incredible difference. One, to say first, you saw there's at least no guideline recommendation for non-STEMI, but certainly used there in ACS based on Acute, things. And then electively we can have a conversation. But in STEMI, I have to say our lab probably in practice, having reviewed the Horizons trial data, probably have made a shift from probably using unfractionated heparin with some provisional 2B3A to bivalirudin, which was, I'd say, over 50% of the utilization in STEMI. The EUROMAX trial did open our eyes. We were all very uncomfortable about that early stent thrombosis. Mm-hmm. Our upfront antiplatelet is ticagrelor in everybody with ACS, and so we thought that would help some. And then there were all these sort of, I'll just say, experimental regimens going on by interventionalists, continuing bivalve for 4 hours, trying to do different things to say, how do I affect that? Now, in EUROMAX, they actually gave it in the EMS truck and continued it on and still saw the stent thrombosis risk. And although you showed the primary endpoint of death and major bleeding, all the efficacy, which you say, MACE endpoints were exactly the same.
Yeah, it was
right?
just bleeding reduction.
Death, MI, stent. If anything, it was going the other direction. So before HEAT, we had started to reevaluate some of our practice. I would have said EUROMAX made us think not only is the stent thrombosis practice real, It doesn't seem to be attenuated with upfront ticagrelor or good antiplatelet, and it doesn't seem to be attenuated with prolongation.
Right.
With that data, we had already started to say maybe with all the things going on, we should start to move the other direction.
And Neal, what were you guys doing?
We were and still are using nearly 100% bivalirudin. I'm very impressed by HEAT. I like BRAVE 4. These are great trials to get us thinking, but let's face it, we've heard a 10-minute presentation. We haven't seen any data in print yet, and it's going to take some time to digest this. This is a wonderfully disruptive study, and it makes us question our dogma in a very critical way. But I think without the data in front of you, it's a little irresponsible to change your practice based on a brief presentation.
That's I think that's a fair statement. We have not seen it published yet.
So what do you think about EUROMAX? I would say in the face of now, if you were practicing 100% bival, in the face that there's a mortality reduction with bival in one trial, the second trial doesn't show that.
Yeah, no, I think
and
it's
that trial says
I mean, again, the mortality reduction, of course, is what really pushed it.
That's what pushed us,
and so we don't know if that's
Seems
real
unlikely,
from it. But I think so we'll talk talk HEAT again. So most people are aware of the HEAT trial, a single center randomized trial of 1,800 plus patients, purely randomized to heparin versus bivalirudin. Without mandatory 2B3 inhibitors, again, low rate of 2B3 inhibitors. Most patients got new antiplatelet drugs, either prasugrel or ticagrelor, 85% transradial PCI, and lo and behold, certainly no benefit of bivalirudin, no reduction in bleeding with bivalirudin, and trends, basically towards harm, driven predominantly by the stent thrombosis. Once again, for that. So. Just a few comments on what you think HEAT will do. I think then we have to wrap up. If you want to talk about the ethics, I think that would be fun, but probably for another day that we need to talk about the ethics.
The picture is very simple. Because we are using a very nice technique that is primary PCI, and that works very well. And the major hazard is stent thrombosis. So why use a drug which is associated with stent thrombosis, in the setting where you have a thrombotic storm and you want to avoid it? And this is very simple. And it has been very consistent, the excess of stent thrombosis in all these, bivalirudin trials. So.
And I assume your center is almost 100% radial. Are you radial?
Yeah, it's 95% for STEMI. So it's time to switch to the third way, which is henoxaparin.
Okay.
With very consistent data.
That one's going to still take the U.S. some time to get to get to that. Manesh, what I mean? Are you going to?
I guess
really consider this.
My take from HEAT is I want to congratulate them for doing a single center study that put in 1,800 primary PCI patients. It tells you, if anything, they probably got all the broad spectrum of STEMI patients at their institution. So that's a strength.
And I think 99%.
99%. So that's a strength for me. Very simplistically carried out, both FDA-approved agents. So I think provocative. What I would say from the three trials, Horizons, EUROMAX, and HEAT, is one, stent thrombosis is real across all three.
It's got to be, yeah.
Two, it becomes harder and harder to believe that there's a mortality reduction with the bivalirudin strategy. Whether you agree with bleeding or not, radial or other things may attenuate that. So now the conversations become about ease of administration, cost, and other things.
Right. I think that's, I think there are, subtle issues with the HEAT, HEAT trial. Again, their door-to-balloon time was so fast.
Yes, sure.
It was, 29-minute door-to-balloon time. They obviously take call in hospital all the time. Yeah. Remarkable performance, and that may have influenced it somewhat. So I think we have to be very careful with generalizing it into a U.S. practice, which is still predominantly femoral.
Sure.
Still longer door-to-balloon times, other sorts of things, but it is really provocative. Neal, final word on HEAT?
I think keep your eyes on it. I think it's going to make you rethink things in a big way.
Well, again, I want to thank all of you for a real lively discussion, for sharing your honest opinions, and for being here and joining me at TCT Asia Pacific 2014. That's all for now. Thanks very much.
Thank you.
Thank you.